We are now going to move on to tendon dysfunctions. So we'll first talk about tendonitis and tenosynovitis, specifically covering common tenosynovitis, and we'll talk about DEQUERVAIN, intersection syndrome, as well as digital flexor tendonitis and trigger digits. And then we'll move on to tendon ruptures, including the most common one, a mallet finger, as well as the jersey finger. So as we all know, tendonitis is an overuse kind of injury where when we talk about the itis, we're talking about an inflammation, but we know that quite often this develops into tendinosis in a typical tendon. But in the hand here, we have compartments for the extensor and the flexor tendons, and they have a tenosynovium that wraps around one or more tendons of the extensor or the flexor region. So a tenosynovitis may occur with rheumatoid disease, diabetes, a hypothyroid condition, and it can also just develop from overuse. And typically what we see when a patient comes to see us, they have local tenderness over that particular tendon or tendons. And then if we apply the selective tissue tension principles, meaning if we stretch that tendon, it'll be uncomfortable. If we actively use that tendon, it'll be uncomfortable. And if we resist that tendon, it'll be uncomfortable. And in general, our conservative management would be medication, including anti-inflammatories if it is an itis, splinting to prevent excessive activity in that tendon, patient education to modify their activity to minimize stress to those tendons, progressive stretching and strengthening, as well as icing to cool the area down following activity. So DEQUERVAIN'S disease is a progressive tenosynovitis of the first of the extensor compartments in the hand, and that first compartment consists of extensor pollicis brevis as well as abductor pollicis longus, APL and EPB. And what happens is there's an irritation of the synovium wrapped around these tendons. We can get some degeneration and thickening of the tendon sheath. And this usually occurs due to overuse or repetitive tasks that usually cause the finger to sit in abduction and extension. Quite often it's because of overuse. It could be compensating for weakness elsewhere, but there's tenderness to pain over those two tendons. Your patient will typically describe the onset as being gradual. There's point tenderness along the muscle belly, but more so over the tendinous junction. There's pain with wrist ulnar deviation as well as thumb flexion because those two motions stretch the muscles. There may be some crepitus with movement of the thumb, but active and resistive abduction are uncomfortable. What you have to be thinking about in the back of your mind if your patient has complaints of discomfort in this region, it is, those two tendons do go over the scaphoid. You have to be thinking that there could be a possible scaphoid fracture as well as arthritis. As we mentioned in a previous module, we know that arthritis of the thumb is quite common. Kienbach's disease or osteonecrosis of the lunate could also be another possibility. So what is the typical treatment for DEQUERVAIN'S disease? Rest, anti-inflammatory medication to calm it down, and splinting. And a splint is shown here where the thumb is in a spica, so the DIP of the thumb, or the IP I should say, of the thumb is able to flex, but there is no movement proximally, and so the thumb is not able to abduct or extend. And the thought is to kind of decrease the activities in those muscles over a 3 to 6 week period, followed by eventually range of motion and progressive strengthening. It has been shown to be pretty effective at reducing the complaints of pain and the functional limitations. The next common tenosynovitis is known as intersection syndrome, and this occurs kind of where the first extensor tendon compartment and the second extensor tendon compartment meet. So the first is APL and EPB, and the second is extensor carpi radialis longus and brevis. So where those two groups cross is a common friction site, and it can cause some irritation. So there's tenderness over the distal aspect of the forearm. So this tenderness over the distal aspect of the forearm is a little bit more on the medial side of the distal aspect of the forearm, whereas for DEQUERVAIN'S, it is definitely on the lateral distal aspect of the forearm. So again, we could also apply the same selective tissue tension. So if we stretch or actively use any of these four tendons, it will cause a replication of pain in that region. The interventions are to splint to prevent or decrease the activities in these tendons, use modalities to decrease pain, and patient education to avoid those activities that flare up or replicate the patient's discomfort. Moving on to digital flexor tendonitis, and as well as trigger digits. So typically what we see is a thickening. We know that there's a flexor pulley system where there are 5 annular and 3 cruciate ligaments in digits 2 through 5. So we see a thickening at the A1 pulley, and there's some swelling and inflammation that occurs, and then we get thickening of that flexor tendon sheath with repetitive overuse and microtrauma. More common in diabetic patients, young children, as well as menopausal women. So we see it more so in the first to the third fingers. And the base of the affected finger is tender. And when they flex that finger, we get this trigger phenomenon where the tendon is not moving smoothly through the pulley system, and it kind of feels like it's catching along the way. So what do we do for these individuals? We can do some MCP block splinting for approximately 6 weeks. We educate our patients in terms of tendon gliding exercises. Medically, there may be some injections that are placed in the flexor tendon sheath. If these conservative measures do not work, there can be surgery to release the tendons, or to when we say not release the tendons, but to increase the flexibility of those annular pulleys, or potentially cut them if need be. Next, we're going to be talking about tendon ruptures. So flexor tendon ruptures certainly can be from trauma, or they can be from inflammation and progressive degeneration of a tendon that occurs when we get into tendinosis. Flexor tendon repairs protocols, I should say, vary depending on if it's partial tear, full thickness tear, and where exactly the tendon ruptured. There are several suturing methods that allow for early active mobilization, and the items that tend to affect tendon healing are the nutrition state of the individual, the area in which the tendon was ruptured. We talked about in class the different zones of tendon injuries. And also the presence of the vinculum, which supplies the tendon and the tendon sheath, will certainly have an influence on healing. So like I mentioned, there are several flexor tendon repair protocols. Some look at early passive mobilization, where we passively flex the fingers and then the patient can actively extend within a splint. And there are also other protocols where we have early active motion, where the individual can actively flex and extend within limitations of a splint. And the pictures here are just showing you some examples of that. So on the left, you could see that the fingers are passively flexed, and then the patient can extend in the splint. And on the right, you see that those rubber bands are connected to a forearm splint, and also distally connected to little ringlets on the ends of the patient's fingers that are holding the patient in that flexed position. two of the next two tendon ruptures that we're going to be talking about are a mallet finger as well as a jersey finger. So a mallet finger is one of the most common athletic injuries of the hand. Typically what happens is that there is a force applied to the tip of the finger causing an acute flexion force, and it ruptures that extensor tendon that inserts onto the distal phalanx. So we see the patient, they have a flexion to deformity at the DIP joint. We can passively extend them if we get them early enough, but they are unable to actively extend to full range of motion. They may also have a large fragment fracture, so where that tendon avulsed a piece of the bone off. And so in terms of interventions, certainly if there's a big avulsion fracture, what they'll do is they'll take a pin, and that'll go through the distal end of that tendon as well as that fragment of bone, and then they will tack that down into both the middle and distal phalanx. And conservatively, what the patient would be placed in a distal DIP splint that will keep the DIP in either neutral or actually slight extension for an extended period of time, allowing some scarring and allowing that tendon to kind of heal in a shortened position so as to allow the patient to be able to extend. So like I said, the patient is immobilized for approximately 6 weeks with that finger placed in a DIP splint in either 0 to 15 degrees of hyperextension. But if there is a large fragment, they'll immobilize and then they'll do an open reduction internal fixation with K-wires. The splint is discharged when the patient is able to actively extend, and they're able to maintain that active extension. We begin active exercise beginning at 20 to 35 degrees of flexion, and we progressively increase range of motion with resisted exercises at approximately 8 weeks. But really what we want to make sure we focus on is making sure that we don't see the patient develop any kind of an extensor lag. The next tendon rupture that we frequently see in the clinic is the rupture of the terminal, the FDP tendon from its insertion. It is often misdiagnosed. The ring finger or the fourth digit is usually the most common digit to have this tendon rupture off. Patient is unable to flex the DIP of that particular finger because the FDP goes distally and inserts onto the distal phalanx. Now, in terms of interventions, it depends on the severity of the injury, if it's a partial tear or if it's already up to a complete tear. Now, if it's a complete tear, surgery will be required. Next, we're going to talk about peripheral nerve entrapments. We talked extensively about this in the elbow region, so we certainly know that the main nerves, the ulnar, median, and radial nerve, continue on in the forearm to the wrist and hand. So if a patient has complaints of pain in the hand, it certainly can be from a cervical radiculopathy, but it can also be from a peripheral nerve entrapment. The radial nerve, we spoke about this before in terms of the Wartenberg sign, is when there is irritation or entrapment of the superficial branch of the radial nerve. Carpal tunnel syndrome, the most common peripheral nerve entrapment of the upper extremity, is compression of the median nerve as it travels through the carpal tunnel. Ulnar nerve compression, while not as common in the wrist, the ulnar nerve can be compressed as it goes through Guillen's canal, which is a pseudo tunnel that is formed between the pisiform and the hook of the hamate, and the ulnar nerve and artery pass underneath that. Additionally, in this region, we have the complex regional pain syndrome, otherwise known as reflex sympathetic dystrophy. In general, patients with peripheral nerve entrapments report having vague sensory disturbances or complaints of pain that would follow the sensory distribution of that nerve. Quite often it's kind of overlooked and thought that it's just a little bit achy, it'll go away. There may be an underlying disease process that may be going on. In time when there may be progressive weakness, the EMG studies or nerve conduction studies may be helpful to show if there is a problem with conduction. Upper limb tension testing, biasing one of the nerves, can also help indicate if whether or not there's sufficient flexibility or translation of the nerve with movements of the upper extremity. So we'll first discuss radial nerve. So if the radial nerve gets compressed, we could see wrist and finger drop, as well as weakness in APL and EPB, as well as EPL. The posterior interosseous nerve, we mentioned this before, quite often gets compressed as it goes through the arcadophrosche, which is a tunnel between the two supinator heads. It can also be compressed distal to, which is distal to the lateral epicondyle. So what do we see in our patients? We see, like I mentioned, weak wrist and finger extension. We can see finger drop and with wrist and radial deviation. The patient has a weakened hand grip and they're unable to extend their thumb. Wartenberg syndrome, this is a compression of a component of the radial nerve, in particular the superficial branch or the superficial sensory radial nerve. So tendons of the brachioradialis and the extensor carpi radialis longus may press on this nerve and cause irritation and cause these symptoms to appear. The patient notes pain, paresthesias, and numbness of the radial aspect of the hand and wrist. So carpal tunnel syndrome, the most common peripheral nerve entrapment of the upper extremity, is an ischemic compression of the median nerve at the wrist. It occurs as it passes through the carpal tunnel. So compression on this nerve is influenced by fluid retention, pregnancy, infection, renal dysfunction, gout, acute trauma, rheumatoid arthritis, and certainly trauma. Most cases, approximately, I should say, good 50% of cases are related to cumulative trauma in the workplace, meaning the patient's workstation setup is not proper, so that quite often our patients end up sitting in too much wrist extension, causing compression of the carpal tunnel on the palmar surface of the hand and wrist. So it is most commonly seen in individuals between the 4th and 6th decades. This is a peripheral nerve entrapment that is more likely to occur in women than men, approximately 10 to 1. The patient will note intermittent pain and paresthesias into the median nerve distribution. They typically note increased symptoms at night, and I think it's quite often because patients, when they sleep with their arms, or they should say their wrist, in a flexed position. We could see possible median distribution weakness and sensory loss. Patient can have a positive Tinel sign at the wrist, as well as the Phelan sign, which is hyperflexion, hyperextension of the wrist compressing the carpal tunnel. We may have EMG findings indicating decreased nerve conduction. When a patient presents this way, in the back of your mind, you should be thinking this could be a cervical radic that is referring pain, certainly thoracic outlet syndrome. Pronator teres syndrome, we know that's compression of the median nerve as it passes through the two heads of the pronator muscle. We could see fibrositis as well as with wrist joint arthritis that could be mimicking these symptoms. So what do we do for patients with carpal tunnel? Typically, patients are splinted in a slight, neutral to slight extension position at the wrist. Patients are encouraged to modify their activities to avoid those activities that flare up their symptoms. If swelling is an issue, patients may be given a diuretic or anti-inflammatory medication. An ergonomic modification or a workstation setup evaluation may occur, where a patient's workstation setup is evaluated to make sure everything is positioned properly so that there's not excessive forces placed on the body. We could do isolated tendon excursion exercises, which I'll review shortly, as well as nerve gliding exercises. Contrast baths if the patient has continued trouble with swelling. If conservative management it does not seem to be working, a surgical evaluation for patients, especially if there is thenar muscle atrophy or decreased sensation and persistent and intolerable symptoms. So moving on, we have potential for ulnar nerve entrapment. So like I mentioned, this is entrapment at the wrist in Guillaume's canal. We typically see this in cyclists who lean on the bicycle bar, and that we tend to put pressure on the ulnar side of our wrist, right where that ulnar nerve goes into Guillaume's canal. Patient presents with sensation changes in the little and half of the ring finger. We could see hypothenar muscle atrophy or anything else innervated by the ulnar nerve. Patient could present with a positive Froment sign, which is where we had the piece of paper and we placed it between the index and the thumb, and we asked the patient to adduct the finger to maintain the piece of paper in between those two fingers. And as we try to pull the piece of paper out, if we see that the patient flexes their IP or hyperextends the thumbs to keep contact with that piece of paper, it's indicating a weakness to the adductor pollicis muscle, which is innervated by the ulnar nerve. We could see an ulnar claw ham, and we could also see a positive Wartenberg sign, differentiating that from Wartenberg syndrome. So Wartenberg sign is what you see on the bottom picture here. The patient is asked to, you could either have them place their hand flat on a surface and ask them to abduct their fifth digit, or you can place their hand and ask them to bring that fifth digit closer to the fourth. And if they are unable to do that, that's indicating weakness to, or I should say, weakness to the intrinsic muscles of the hand innervated by the ulnar nerve. So what do we do for patients with ulnar nerve entrapments near the wrist and hand? They are placed in a splint, keeping that wrist in neutral, or potentially in a extrinsic plus splinting position, which is what you see on the bottom right here. So what happens is that we get, we can get contracture of the interosseous and the lumbrical or even the hypothenar muscles, and it causes the fingers to stiffen and the hand to become deformed and really functionally disabled. So this bottom, this picture here, the intrinsic plus position is, well, I should say the intrinsic plus hand is the result of an imbalance between the intrinsic muscles and comparatively the weak extrinsic muscles. So how often this happens is really not known, but if you put the patient in an intrinsic plus position, it is otherwise known as a safe position for hands. The hand can be positioned like this for long periods of time without developing as much stiffness as would occur if the digits were positioned differently. In this position, the MCPs are flexed to about 60 to 70 degrees. The IP joints are fully extended and the thumb is in the fist projection. So the wrist is held in extension and at about 10 degrees less than maximal. As I mentioned, we were going to talk about complex regional pain syndrome, or CRPS. You still may read that this is referred to as RSD or shoulder hand syndrome. It can occur as a result of trauma or a direct nerve injury, and it has been described in the literature as having 3 phases, really each in 3 months duration. So the acute phase, first 3 months, the vasomotor instability phase, 3 to 6 months, and then the cold end phase, which is 6 months, beyond the 6 months. Okay, we're going to move on now to fractures, of the common fractures in this region. In particular, we're going to talk about distal radial fractures, and they kind of can be categorized as either a Colles fracture, a Smith's fracture, or a Barton's fracture. I'll discuss those briefly in a moment. We'll then look at scaphoid fractures, which is the most common carpal bone fracture in the upper extremity, carpal boss, as well as hand and finger fractures. Sorry, one thing I wanted to note is when we talk about fractures here, usually one of the most important characteristics is to think about whether the fracture is extra-articular or intra-articular. So extra-articular fractures are usually less complicated. Intra-articular fractures, can either involve the radial carpal joint, the distal radial ulnar joint, or certainly both. And then you're usually going to talk about whether or not it's displaced or non-displaced. So a fracture, just to remind you, that is with an offset of 2 millimeters or more in any of the planes is considered displaced. And it could be displaced in the dorsal direction, the volar direction. It could be displaced radially or proximally. And these pictures should look a little familiar to you. It's when we talked about these before. So there's different types of fractures. We have closed versus open, open meaning that it breaks the skin. And you can see here the upper left, we go from normal and we come all the way down to green stick. In general, excessive tension forces can lead to avulsion fractures as well as transverse fractures. Compression, excessive compression can lead to impaction fractures. Bending can lead to short oblique fractures, and excessive torsion or twisting, think about wringing out a towel, that can lead to spiral fractures. In general, there are 3 phases of fracture healing: the inflammatory, reparative, and remodeling. And in those phases, first we get hematoma formation, then we get soft callus formation, which looks like almost like when you're looking on plain radiographs, it just looks like a little bit of a cloud of white, but the hard callus formation is certainly indicating that the remodeling is occurring. There are different things that augment healing, and they're listed here. Oops, sorry. Other things that can affect the rate of healing certainly is the blood supply, where the fracture occurs, the age of the individual, and the amount of displacement of the fractured fragments is inversely related to fracture healing. And just in terms of age, fractures heal faster in the young because their periosteum is thicker and stronger and more osteogenic. Location, cancellous bone generally heals faster because it has a rich blood supply. And certainly, in general, the blood supply, the vascularity of the bone and the surrounding tissue will certainly have influence. Things that can hinder healing: inadequate immobilization or a reduction, if there's an infection, a loss of blood supply, if the patient has a poor nutritional state, and if there's interposed, meaning that the 2 ends are trying to kind of grow back and stick together, but if there's soft tissue that is now in between those 2 ends, that can impede healing. So now we're going to move on to distal radial fractures, which are the most common wrist injury for any age group. A patient coming in following a distal radial fracture presents with a swollen wrist that has a gross deformity. They have limited motion. It's very tender over the distal radius. Young patients tend to have more intra-articular fractures than old patients in this region. So a COLLES fracture is a distal radial fracture, but what makes it a COLLES fracture is that there's dorsal displacement of that distal fragment of the radius. So when you're looking at the hand, they call it a characteristic silver of arm deformity. So, the fracture is sometimes referred to as a dinner fork or a bayonet deformity due to the shape of that forearm. So COLLES fractures are often seen in people with osteoporosis. And these fractures usually occur about an inch proximal to the radiocarpal bone. Okay. So here you see the plain films on the left is showing the distal radial fracture. You can see that on the far left, and in the middle film you could see that there is dorsal displacement. COLLES fractures usually occur after a fall on an outstretched hand, and the hand is in wrist extension. These are some additional images indicating a distal radial fracture with dorsal displacement of the distal segment. A Smith's fracture is also a fracture of the distal radius, but this time this is also known as a reverse COLLES because instead of a dorsal displacement, we have anterior displacement of that distal fragment. Both of these fractures are typically treated with a closed reduction, meaning that the piece is properly placed and then the person is placed in a cast or a hard splint, but in more complex cases they may require surgery. Here you could see pictures. So on the left is a plain radiograph indicating a distal radial fracture with anterior displacement, and here the Smith's fracture again is a fall on an outstretched hand, but here the wrist is usually in flexion. Additional images here showing the same thing. We get a distal radial fracture with anterior displacement. A BARTON'S fracture is also a distal radial fracture, but it could, and that distal segment could either be, dorsally displaced or anterior displaced, but what also occurs in a Barton's fracture is that there's also subluxation of the wrist. These individuals have a great tendency for redislocation, and they usually require surgery. So this is just showing you here. We see that we see a distal radial fracture, and on the left there's volar displacement of that distal segment, and on the right there's dorsal displacement. But what has occurred along with the displacement of that distal fragment is that the wrist has now subluxed. What are some additional fractures? We have a die punch fracture, which is a depression fracture of the lunate fossa of the distal radius. An ulnar styloid fracture. So an ulnar styloid process fracture is usually associated with radial fractures, and they're rarely isolated. So an isolated fracture of the tip is clinically insignificant. Displaced fractures of the base are usually associated with TFCC tears and can be associated with instability of the distal radial ulnar joint. Radial styloid fractures, also known as chauffeur's fractures, there's displacement of the fragment is uncommon. There can be associated injuries through the scapholunate ligament, but in most cases, a fracture of the radial styloid process is part of a commutative intra-articular fracture. So wrist fracture rehab in general, we're going to get the edema under control. We'll get early motion to the fingers, active motion as immobilization is removed, and then we progress to passive motion and strengthening after healing has occurred.